This video demonstrates creation of a redo radiocephalic fistula in the left upper extremity. We believe full vein mapping should be done prior to each new access creation, and the mere presence of a failure in a given location does not rule out the possibility to redo an access in the same location. A skin incision is then made in the distal forearm centered between the cephalic vein and radial artery. A subcutaneous flap is then created and dissection is carried down until the cephalic vein is exposed. Side branches coming off the cephalic vein are then divided. This is done to prevent stealing of blood flow once the fistula is created. Next, the vein is marked for orientation and to prevent twisting during creation of the radial cephalic fistula. Once a length of cephalic vein long enough to reach the radial artery without tension has been exposed, the vein is divided as far as distally as possible and the distal stump of the vein is ligated with a clip or silk suture. Next, metallic probes were passed to the cephalic vein. This is not our routine, but this was done in this case because of the previous failed fistula and to make sure that there are no unidentified obstructive lesions. Next, the cephalic vein was irrigated, and collapse of the vein with irrigation is a very important sign of low outflow resistance as shown in this video. The distended cephalic vein is then clamped. We then proceeded with exposure of the radial artery. Dissection is then continued with tenotomy scissors, and side branches coming off the radial artery are then clipped. This is done to prevent back bleeding from the radial artery during creation of the fistula. Proximal and distal control of the radial artery is then obtained using bulldog clamps. Moist lap pads are then placed to prevent tangling of the suture during creation of our anastomosis. The cephalic vein is then spatulated. #11 blade is then used to make an arteriotomy in the radial artery. This is extended with pot scissors. Next, we proceed with creation of our anastomosis between the radial artery and cephalic vein using a parachute technique as shown in this video. We try to minimize handling of the intima and being gentle with the vessel to avoid additional vascular trauma. The anastomosis between the radial artery and cephalic vein is then completed. This procedure is performed without using systemic heparin, and the sequence of our clamp removal is venous outflow first, followed by distal arterial, followed by temporary occlusion of the distal arterial and releasing the proximal inflow to prevent thrombi that might have been formed and may get dislodged. The cephalic vein is then dissected free from the surrounding tissue in its proximal part to prevent resistance of blood flow. A thrill is then felt. The wound is then closed in layers with a 3O PDS for the deep dermals and 4O monocryl for the skin.